Right, okay, good morning, everyone. Pulmonary atresia and intact septum and critical PS with intact septum hypoplastic RV, this is what I'm going to touch on. And I'm going today to touch on the hypoplasia of the RV and what we do in this center in order to get the most we can out of the hypoplastic right ventricle. We know that the hallmark of how these patients will do long term is not only the pulmonary valve, the degree of dysplasia and its size, but also the tricuspid valve. We know that we use the Z-score of the tricuspid valve to see whether a univentricular or biventricular repair will be possible. Ultimately, we mostly assess all this by echocardiography, but when we see coronary connections with the ventricle, then we may do something more in terms of imaging CT or a cath at the time of the cath procedure. This is a very busy slide, but in essence, there are four groups, as we talked about. Group 1 is the group that has a tricuspid valve Z-score above -2.5, and this is the promising group that we are going to get biventricular circulation because the right ventricle is usually tripartite on these occasions, and when there is membranous pulmonary atresia, then we can perforate the valve. And then, depending on the right ventricle, you know that we will either do a PDA stent or a BT shunt, and if we interventionists haven't done a good job, then we may ask our surgeon to do a pulmonary valvotomy. And then as groups proceed, like 2, 3, and 4, then the ventricle gets worse, the tricuspid valve Z-score goes down, and then we may end up having a univentricular circulation. This is courtesy of Dr. Grzyb from Poland. She gave a fantastic talk at the APC last month. Essentially, the right ventricle is extremely hypertrophied, as we saw in the previous talk, and the degrees of dysplasia can be identified both here on this slide, both for the tricuspid and the pulmonary valve. So in my mind, there are two major axes of management and determinants of the future prognosis of the fetuses and the neonates with critical PS or pulmonary atresia and hypoplastic right ventricle. The first thing is that when the valve is, presents membranous atresia, you need to open the valve fully. And we attempt to do that in one go in the neonatal period and not do successive balloons as we've seen in different centers in the first year of life. So we open the valve as full as we can with the first cath. And then we take aggressive measures to augment the RV growth. We know from previous years that with the pulmonary regurgitation that is caused by opening the pulmonary valve, the right ventricle grows with time. In contrast to the aortic valve ballooning that you saw in fetuses earlier on, where the valve in the fetal life remodels and the regurgitation gets a little less by the time the baby is born. With pulmonary regurgitation of a newborn, when we open the valve, this will not get less. We will see it more as the end diastolic pressure of the right ventricle will go down. So we need to be very careful to open the valve fully, but not wreck the valve open and cause a lot of pulmonary regurgitation. And then the important message of my talk today, and I'm going to show you a little bit about this, is that we need to be patient after our first intervention and not proceed immediately with the second intervention in the form of PDA standing or BT shunt as we used to do in the previous years. So let's have a look at things the other way around of what we have attempted to do the past few years. We know that for the hypoplastic left ventricle in borderline LVs, we have measurements by MRI where the LV needs to be above 17 mL per meter square for us to be a little bit optimistic that this neonate might end up with biventricular circulation. But do we have such volumetrics for the RV? Not really. So this is a recent paper from a Korean journal where it looked at hypoplastic right ventricles in several forms of congenital heart disease. And in essence, I don't know if you can read it, but the volumetrics of the RV, for them to call it hypoplastic, was an RV of 20 mL per meter square. Okay, but we don't know whether this is actually adequate for biventricular circulation. Let's go back in papers from the 90s, 1992 from Jack. Changes of right ventricular size and function in neonates after valvotomy for pulmonary atresia or stenosis with intact septum. The hypoplastic ventricles had volumes of around 16 plus minus 6 mL per meter square. When we then open the valve, you know this is a pressure-loaded ventricle, the ventricle will come down. And the volumes, as stated in that paper, would go down to 10 mL per meter square. That's angiographic and echocardiographic evidence. You know that we don't do that these days. We have MRI. And then look at the conclusion at the end. After the hard period of the ventricle volumetrics going down, the patients then start recovering, and the growth of the right ventricle is at a rate that parallels or even exceeds the rate of somatic growth. And this is our motto for waiting around for these patients without a second intervention. So let's see a real-life example. This is a patient of Dr. Laskari, fetally diagnosed with critical pulmonary atresia, and as you see, very hypoplastic and hypertrophied right ventricle. Already from fetal life, the TR gradient was 125 mL per meter square. This is the echo of the patient when he was born, and you see again that the ventricle is hypoplastic and the gradient of the tricuspid valve is 138 millimeters mercury. This is the initial RV angiogram that we did, where clearly we see that the ventricle is small, hypertrophied, the pulmonary valve shows critical stenosis. There is regurgitation, severe regurgitation of the tricuspid valve with blood going back into the hepatic veins clearly, and very large right atrium. This is common. And then we do full ballooning. We either do sequential balloons, as fewer as possible, 1 or 2 on this first session. You see the critical PS, we open it up fully, and then we repeat the angiogram, and one can see that, of course, the right ventricle is the same, the TR is the same, but one can see that there is also infundibular spasm. The right ventricular pressure still is high because there is right ventricular outflow tract obstruction because of that hypertrophied RVOT. And then we wait. We wait for a week, and the first week the patient is on Prostin because they need some alternative flow to the lungs, and we do other measures that I'm going to talk about in a bit. And this is a pulmonary atresia patient. Clearly nothing goes through the pulmonary valve, where we perforated the valve and then opened it up fully with sequential balloons, as you see in that panel below. So the hypoplastic right ventricle is not only seen in cases of critical PS and pulmonary atresia, but there is such entity genetically coded on its own. So there are small and hypertrophied right ventricles with reasonable pulmonary valves. And we know that there are genetic factors that will code the hypoplastic right ventricle. And we know now that there is epigenetic regulation. So there is things that we can do on this right ventricle to get it better. There's also been copy number variants in this form of hypoplastic right ventricle that affect crucial genes and signaling pathways that are involved in the development of this right ventricle. And there are genetic and epigenetic factors that they play both distinct and additive roles in this maladaptive myocardial remodeling. So like with the aortic stenosis, these diseases are not diseases of the valve alone, but they are diseases of the ventricles and their myocardium. We know that the maturation of cardiomyocytes starts at mid-gestation and then continues into adulthood. And there is this tightly regulated molecular program that will regulate these structural changes. And in babies with congenital heart disease, this program obviously is derailed as it goes towards finalization. And the anatomical defect of what we're talking about, the atretic pulmonary valve, is actually associated with the failure of the cardiomyocytes to reach full maturation. And the authors of this paper, Madedu, from the Journal of the American Heart Association, state that on these patients, there are risk factors that will actually impede what their full potential is. What are the risk factors? Open chest surgery, cardiopulmonary bypass, non-self-recognized grafts, residual defects, psychological stress, graft failure, reoperations. They will cause inflammation, dysfunctional proteostasis, mitochondria remodeling, oxidative stress, and things that will then lead to heart failure. So if I now turn you to the mode of what Dr. Michel Benke was saying yesterday of Austria, let's see that this is now failure of the right ventricle and downregulation of this cardiac contractile apparatus of the right ventricle because of this problem in the cardiac maturation and the upregulation of the immature isoforms. And the authors state that this persistent problem in the maturation of the myocytes of the right ventricle might actually explain why patients with hypoplastic right ventricles have persistent right ventricular systolic and diastolic dysfunction despite our efforts to do valvotomies, open valvotomies, or when we open the valve with percutaneous techniques. And the authors also state that the alteration in the contractile protein developments is dissociated from defects in calcium handling in these patients. So what can we do? Structurally, we will open up the valve, okay, and then we wait. And what we do in this department is that we use drugs that will help the right ventricle, whether this is a hypoplastic right ventricle as isolated event, which we've had 3 cases over the last few years, or whether this is a right ventricle in the setting of critical PS pulmonary atresia. So we would start beta blockade on day 1 immediately after the procedure, which is crazy because the patients are sick, you need inotropes, and they are hypoxic, they still have saturations in the 70s and 80s because there is an atrial septal defect that shunts right to left. But we give them propranolol to deal with the RVOT spasm. Okay, this is not new. In terms of inotropes, we would not give them anything else than milrinone, and we will also give them sildenafil. And I always get the question, how do you know that this patient has pulmonary hypertension? Or I get the question saying, but you measured PA pressures and the PA pressures were not high. Why do you give sildenafil? Well, we give sildenafil because it has beneficial afterload independent effects on that ventricle. And recent studies, there's a lot of animal studies regarding sildenafil on mice. It reverses the hypertrophy of the mice, and it accelerates what nature would do anyway. So we use sildenafil to accelerate that. And there is more things in our hands these days. We could use, I haven't, but we could use biomarkers such as Ella-Bella, which is a biomarker that was identified in zebrafish embryos in 2013. And it is expressed, it's a hormone expressed in the heart, the blood vessels, the stem cells, prostate, and kidney. And it is used as a biomarker in pregnant women with preeclampsia. And in this setting of the patients that we have intervened on, it seems that there is a negative association between our hemodynamic effect and the Ella-Bella concentrations, in that when you've had a successful offloading of the right ventricle, then this biomarker will go up. And this is how some teams will follow up patients in terms of whether they will need a second procedure or not. So to summarize, what we do is we open up the valve fully. We give the patients propranolol, milrinone, sildenafil, prostin continuation, and then we wait for about a week. And we see the saturations go up towards the end of the first week. We keep the surgeons away. We keep my PDA stents far away. And we then see the patients have a second, better week, and by the third week, they are already off the ventilator. And we also see huge improvement with bottle feeds. And why is that? I've often thought about why bottle feeds is so important and helpful in these patients. I think it's the sucking motion that increases the preload of the right ventricle. And the preload of this small right ventricle is extremely important from day one. And I didn't tell you this first paper from Del Nido and colleagues that came out recently last year, which basically says, don't offload that right ventricle. It will need as much volume as possible. And I have seen patients, adult patients, that in the first few years of their lives, when they were neonates, they had a balloon atrial septostomy. No, this is the wrong thing to do. When we have hypoplastic left ventricle, we want a restrictive atrial septum for the left ventricle to grow. Similarly, when we have a hypoplastic right ventricle, we don't septostomize the patients. We don't want right to left shunt. We want to push this ventricle to its limits, and that's why we are so aggressive with this medication. We then, after we bottle feed them and they are okay, we send them home with accepting saturations about 85%. With bidirectional shunt, and then the right ventricle, nature takes its course, the right ventricle grows pretty quickly and they come off medication at about 4 to 6 months of life. So our cohort here with pulmonary stenosis patients and pulmonary atresia was 90 patients, but we care about the neonates, so we've had 34 neonates and 14 of them had hypoplastic right ventricle, and 3 of them had tricuspid valve Z-scores less than -2.8, which we know that they are the difficult population. In the first years of me coming here, I did 1 PDA stent, and that didn't avoid surgery because she then developed muscular RVOTO by the age of 8 years, was operated by Dr. Mitropoulos and is extremely well. And there were only 2 patients that I did a repeat balloon. As I said, I avoid repeat procedures. So in conclusion, when we have this substrate with hypoplastic RV, these are complex lesions and they don't just depend on the characteristics of the tricuspid, the pulmonary valve, but also the RV and its myocardium. We need to make sure that we do early and complete pressure unloading coupled with volume loading of the right ventricle and aggressive pharmacological therapy in the first week of life. So medical management with prostin in the first week of life and avoid a second percutaneous or surgical intervention until the second week of life is important. We have now data that the fate of the hypoplastic right ventricle long-term is likely to depend not only on genetic but also epigenetic factors. And we do have these days, and we will have more biomarkers to assess of what we've done, what we do, and whether our patient needs something extra. Thank you very much.